please help spread the message of frequency-specific microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about frequency-specific microcurrent.
I'm so glad that we have this every Wednesday.
We don't have to fly up here.
No, but it's one of those things where sometimes running around and I'm at the clinic and I'm like, oh my God, I have to go back on a Zoom call. And then it's no. This is the perfect time to just sit, pause, connect. And the word pause is something that I want to talk a little bit about today. That it's okay to hit the pause button.
It's essential to hit the pause button.
Yes, for so many different factors. Sometimes you need to do that with the patient. Just pause, just stop. If something's not working, it's okay to just stop, refer them out, get a different set of eyes on it, write down the history sometimes, especially for the really complicated histories.
One of the things we've done when I open the clinic in Troutdale, instead of spending an hour and a half on a history, the patients are asked to come in with a written linear timeline, dates, like year, just January 2010.
Yeah.
On the left, and then what happened on the right.
Yeah.
Okay, fallen tree across the road. I drove through it. Excuse me? Yeah, there were 4 of us in the car, and the only one that got hurt was the one in the front that wasn't wearing a seatbelt, but I was fine. Okay. And then you go down, and there was another. You got rear-ended in 2010. What kind of car were you driving? I don't know, like a Toyota Celica. What hit you? Oh, a Ford F-150 pickup. How fast was he going? I don't know. I was at a stop sign and I had my foot on the brake and he thought the light was green, and so probably 35 or 40. And so the written timeline was, oh, that's right. I saw this patient after last Wednesday. And then I get to 2010, a long time ago, 13 years ago. And she had a little bladder leakage. And so the OBGYN, so we'll put some mesh in to do, because you've got your bladder is prolapsing through your abdominal wall. At which point I asked her to put her hand on the desk and raise her little finger. There was that. Nobody had ever checked her for Ehlers-Danlos before. They put the mesh in, and they used mesh that had been recalled the day of the surgery. She had an infection, temperature of 103. The blood work done a month after had neutrophils at about 7.8, and they should be less than 7 if I'm recalling correctly. Anyway, what was really fun is that when I got to that point in the history, my language got a little colorful, and I went, what the? And she said, I have been waiting for a doctor to do that.
Yeah.
And then I read further on in the history, like the number of years that doctors ignored her complaints of abdominal pain, didn't do a CBC to look at the white count, didn't do a palpation, told her it was in her head, told her there was nothing wrong. At which point I went, what the actual? And she said, thank you. It was very validating. And so she had really horrible neck pain. And I did a sensory exam and reflexes. And I said, have you had an MRI of your neck? Yeah, they said it was normal. Can you find that MRI? Not normal. No, like way not normal. The lower two branches of the trigeminal nerve were C2 was numb. Lower two branches were hypersensitive. So for those of you that don't remember, that loop of the trigeminal nerve goes down as far as C4. So if you have a 4-5 disc, it will irritate the lower two branches of the trigeminal nerve. The upper branch will be normal. These two branches will be odd. C2 was numb. Back of her head was icky. So I didn't touch her belly the first day because that area was so emotionally charged, sensitized. I didn't know if I was going to have to do intervaginal work. I didn't know where the scar tissue was. So I just did supine cervical practicum and then treated the C2 nerve root. And her pain level went from a 7 or an 8 down to a 1. She was all happy. The next day we worked on the scar tissue in her abdomen, and I used the frequencies for infection. They didn't do much because in 2018, so 10 years after the first mesh was put in, another doctor finally looked at her abdomen, looked at her blood work and said, this has to come out now. She went into the emergency room with severe abdominal pain, went to a doctor, had surgery like 4 days later. I treated for infection. Not much happened. And then I just started palpating for where the anatomy should be. So over on the left side, just inside your pelvis, there should be something that feels like a sausage casing full of oatmeal. That's your sigmoid colon. And I put my hand down there and went, it's not here. There's no thing here. So I felt over and the sigmoid was like midline. Went on the right side. The cecum and the descending colon should be in the pelvis. Put your hand down there. No sausage casing, no oatmeal, no nothing. Gone. It too was midline. You had to go 3.5 centimeters towards the middle to find all that stuff. So I spent an hour taking apart scar tissue on her abdomen. And it all happened because patients are asked to come in with this timeline. Then the second day she brought in the MRI results, the written MRI report that her GP told her was fine. She has a disc bulge at 5'6", touching the thecal sac. She has a disc bulge at 6'7", touching the cord from the front, and the set degeneration that compresses it from the back. So she has mild to moderate spinal cord stenosis, which explained the tight quadriceps and leg muscles that she thought were coming from her abdomen.
Super similar story that I had with a patient that I've seen 4 times or so, getting just very mild progress, but it was the same thing, asking for imaging. I've had it, it was normal. And then you treat it based on that phrase, it was normal, until you know better because it never not works. There was disc bulging and mild stenosis 10 years ago. I can't imagine what it is now. So this is what I mean about hitting the pause button and saying, I'm going to stop doing this because I think we need to investigate further and get a clearer picture of what's happening. It's really not hitting the pause button. It's actually launching them into a better direction because you're getting a clearer picture of what's going on. So it really bothers me when you look at the report and this isn't normal. This wasn't fine. There are things that you should have been aware of because 10 years ago, you could have done corrective exercise. You could have had different therapy to help stop that in its tracks. And it really bothers me when I hear people saying, oh, it's what a back should look like in someone's 50s. Maybe, but there are things that you can do to stop the progression. Don't just accept it.
How do you read that says mild to moderate stenosis at 6-7 and then tell the patient that it's normal?
I'm not sure. I've lived this week really frustrated.
And when everybody that's listening has taken the core, when I talk about do reflexes, do sensation, she had hyperactive patellar reflexes. Her C7, her triceps reflexes were hyperactive, which meant there was cord inflammation above C7. C5 was hyperactive. Cord inflammation above the level of the reflex means that the descending inhibitory reflex or impulses are slowed. They can't get to the reflex in time to make it a +2. It's a 2 or a 3. It's too brisk.
Mhm.
So you can tell sensory exam, the reflexes will tell you what the MRI should look like. And when the sensory and reflexes don't match what's in the MRI, that's read as normal. And I think for FSM practitioners, it's different because it changes what we do.
Yeah.
On her, I had to run 81 and 10, increase descending inhibition to get her leg muscles to relax, get her trunk to relax.
Right.
Can't take a deep breath. Her trunk was all because of the abdominal adhesions and the loss of descending inhibition. So maybe that's why FSM people pay more attention.
For sure. I'm thinking back to the days before. As a manual therapist, you have to be mindful of disc herniations. You take off splinting or muscle guarding that is there to protect the spine, and that patient's going to get worse. But yeah, it does change. It changes things because we want to be specific and we want to dial in the treatment as fast as possible. So whereas something might have been in the back of my mind before, it's definitely at the forefront of my mind because I want all the information. It just makes you better.
That's what I love the most about FSM practitioners is they want to be better. We have a tool that lets us be better. And as you say, makes us be better. But an awful lot of what we pay attention to, nobody else pays attention to it because they can't do anything about it.
Yeah.
This lady had multiple ankle sprains, a bladder prolapse at the age of 30 something.
Mhm.
That's not normal. But nobody had ever checked her for hypermobility, and she was a gymnast. Nobody ever checked her because they can't do anything about it. And because we have a way of approaching hypermobility or Ehlers-Danlos, we go looking for it.
Yeah. I see frequency as, because I used to just think about the limbic system and the midbrain, just go to the corner, just have a timeout. But it's almost like that with every tissue. It's almost like you have to treat every tissue and every pathology like a screaming toddler and getting down to their level and saying, I see you. I know you're freaking out. Just give me a minute. It's going to be okay. This is safe. And they're like, okay. And it's literally what I feel like the conversation that I'm having with every question that I ask, with every exam that you do, every palpation that you do, every range of motion that you do, you're just trying to get as specific as possible and seeing everything. And again, that goes back to not mashing things with your hands. You're asking questions.
And because of all of the abdominal trauma, I ran concussion and vagus on one machine, and I had one precision care or custom care running from neck to feet running 40 and 89 for a solid hour before I ever touched her abdomen. I had one quiet the spinal cord because the abdominal pain had been so intense for so long. Those pain pathways are sensitized.
Yeah.
And everything's amplified. So I ran quiet the pathways in the spinal cord, but quiet the limbic system, quiet the midbrain. Before I ever touched her abdomen.
Yeah.
Then you touch the abdomen.
Because treating someone's abdomen, even though I treat the abdomen first before I treat the low back, it almost does seem backwards because it is a very vulnerable area to be treated. People will automatically tense up, which gives me a very organic segue to a study, and I should have popped it open. I was talking to a colleague friend of mine, and we're talking about muscle splinting or muscle guarding, which is a protective mechanism.
Right.
Especially in the multifidi, will splint bilaterally to stabilize and protect a segment in the back, especially over top of a traumatized disc. However, muscle splinting and guarding has less to do with pain and more to do with anxiety. There is a study showing that. I believe it was through NIH. And I'll find it and I'll put it up. I'm going to tag it into the sports course, because when you think about compensatory movements, it doesn't necessarily happen with pain. It's the anxiety attached to that movement pattern that causes the splinting to happen or the guarding to happen. So yes, it can happen protecting a disc, but like I said, when you're treating the abdomen, just think about what happens when you put your hands towards someone's abdomen. They're going to tighten up right away. Like, it's the anxiety, it's the apprehension, it's the fear. So this is what I keep talking about, safe.
And I'm not sure the anxiety is conscious. It's not like I feel anxiety.
No.
It's that my midbrain, the way you phrase it in the sports, and I've stolen and put in the core, is afraid to move it. It's a combination because of what we can do with FSM. You think about the pathways, sensory cortex, everything goes through the limbic system. Is it safe? Is it safe? And then the cerebellum is the one that says, nope, not going to move that. Nope, I can't. So it's a pathway, and that anxiety is physical, not emotional.
Right.
The patient doesn't say, I'm afraid to have you move my shoulder, or I'm afraid to have you touch my abdomen, or whatever. The brain says, this will not move.
Yeah.
And because we can quiet down the brain, I think it requires us to be more considerate.
Respectful.
So you lay your hand. We are going to redo the differential diagnosis video and probably the abdominal adhesions video.
Mm-hmm.
And it's have your hand flat and just the dips.
Yeah. The communication that happens too, slowing things down with FSM, instead of jumping on tissue, it is explaining, I'm going to put my hand here, I'm going to press here, and I'm going to do this. And you probably won't feel much, but I'm just going to feel what I'll say the fascia, because that's what I'm now, after all these years, I feel like that's what I'm reading first, that initial layer of smush, or where it bounces back and it's done, right? And so the explanation sometimes can really just, because like you were saying, it's not conscious, but sometimes making it a conscious awareness of what's happening can help that loop, because you're explaining that it is safe. And there may be a bit of a back and forth. This is not safe. Yes, it is. This is not safe. Yes, it is. But that's
not safe. And then in this section where we talk about working on muscles, the number of times I have in all caps, wait, run the frequency. When it loosens by 1 to 2 millimeters, follow it down. And it's like and that's the pause button, is follow the frequencies down.
Yes, I'm so glad that you have that pause, and I'm going to borrow from you. See, we share.
Yes.
I do find, because the sports course is so heavy with manual therapists and PTs and DCs that are used to just going, pressing,
Forcing.
and like I said, I had treatment for my hip, and it was terrible because he wasn't waiting and I wasn't ready. And the more he forced, the more I tightened up. And this absolutely was a conscious muscle guarding, splinting. And I'm like, we have to stop, because you are never going to access that deep tissue when I'm like this. And I don't know how to help you.
Yeah. And in the
Other than go take the course.
we do the supine cervical practicum.
Yeah.
And the people that have, it's painful, the poor things, the people that have the most trouble are the physical therapists, the osteopaths, and the chiropractors that are used to getting in there and forcing that tissue to do it. And it's stop. Let the frequencies do the work. And waiting. And this is the rule, no matter where you're working.
Yes.
Put your fingers on it. You're treating inflammation, toxicity in the liver. Put your hands on the abdomen. Wait and find out what the frequencies tell you. It's why we do the supine cervical practicum first. Number one, it's 50 to 60% of the patients that walk in anybody's door. You do the supine cervical practicum and you're going to make somebody feel better. But that practicum specifically is the one where you learn that this frequency combination only does this.
Right.
And that does that, and that does that. And they get to the bottom. And so we've done the ligaments, the nerves, the facets, we get to the discs, the muscles are all pudding. I say, okay, now we're going to do 91 hardening in the fascia for those of you that are fashionistas. And hardening the fascia does absolutely zero, nothing, because we've taken care of the underlying drivers that make the fascia tight to protect it. The weird thing is we do increased secretions in the fascia, which you think would make it fluffier, and it gets smushier.
Yeah.
That's confusing.
It used to be confusing until I saw this video. I believe it's called, it's strolling under the skin, right? And that, to me, whenever I see that, I'm like, oh, that's why it works, because you just see the water molecules going through.
Little droplets.
Yeah, this little lattice. When you think of anything that's dehydrated, right? It's just, I'm gonna take a little lateral move here. There's this woman that I used to follow who did these recipe hacks all the time. Busy mom, I've got athletes at home. I was all about this. And she would use beef jerky and cut it up and put it in these mason jars that had noodles and water and seasoning. And then you just heat it up, and then the dehydrated beef jerky would hydrate, and you had some extra protein in these jars. That was my
soup.
So I think about like the IT band and high fascia areas as beef jerky. And when you hydrate it, it's obviously not as hard. It's more fluffy.
Yeah.
It's sinkable. Yeah. And I want to go back again to the safety and something too. So I was going through some old notes that I had from a business meeting about advertising and using Yelp reviews and all this. And before using Yelp and Google reviews in the medical field, we didn't see it, but now everybody's leaving a review, and people there's an 8-to-1 ratio of, for every one bad experience, you need 8 positive ones to negate the bad. And I wonder what that ratio is with movement sometimes, because like you said, you have the subconscious of going, that's going to hurt. And it's not. Oh, it doesn't hurt. And I know it's got to be probably closer to 800 to 1. And again, the faster we can override that and make that midbrain safe and confident, and even more so than excited to move and joyful to move, because then you build on that trajectory.
Yeah.
It is. And when I've got a frozen shoulder patient right now that came in at maybe 20 degrees, and now we are at 100 and something, like beautiful. But it's this last little piece that is like the hardest. And it's like losing the last 5 pounds. So you're right, like closing that gap of, okay, it's safe, but are you excited to move it is a whole different.
Yeah. And explaining to a patient. So there's two pieces of it. One, so they understand the process cognitively, but then because we can manipulate the nervous system directly to change the anxiety or the fear.
Apprehension. Yeah.
And so this patient came in, her first visit was Thursday. Her pain level, she was really sensitive because she said, it hurts a 6, but I minded an 8. So when they minded an 8, they're centrally sensitized.
Yeah.
So by Friday at 3 o'clock, her pain level is a 0. We had to teach her to walk again, all of that. And then I had the conversation. I said, okay, when somebody's been in pain for a long time and they have a history like yours where people have ignored them, you've had all of these bad things, but nobody treated you well. There are emotional stages that people go through that are characteristic that I didn't understand 30 years ago.
Mm.
And it may be different for you. It's like grieving when somebody dies. Nobody does it the same way. But first, you're really happy. And then you get angry. You are now allowed to feel angry with the people that mistreated you. Then there's a period of being afraid that it's going to come back. That's why we treat them twice a week for 4 to 6 weeks, so that you can get them through the afraid it's going to come back. Then usually at some point they do grieving over what they lost.
Yeah.
When I only have somebody for 2 sessions, I go right to that. I'm a terrible therapist. I just tell them what's coming and let them see it.
Yeah.
And I said, you've had basically 15 years of pain, life-altering stuff. And if we're lucky, your pain's a 0 now. Some piece of it's going to come back. But look at what you learned. You learned patience. You learned empathy. You learned whatever. And with any luck, you get to get rid of the pain and keep the wisdom. And so it's like showing somebody a map and say, you're here and you're going to end up here, but this is the way the road looks.
And I think that's such an important part of anybody's journey, is when they have the courage to better themselves and to find somebody to help them with their healing process, but to have that person to give them a plan or to give them a prequel of what it's going to look like. Because I think so much of their journey that's led them up into finding us has been blinded, and every turn they've been hit with something else. And so I think it is such a relief, and it is that moment of when you say, you know what, it could get worse before it gets better. And this might happen, but these are all stepping stones that we're going to look out for, and we'll adjust. And we're working together, and we're going to get you over here. And I think sometimes, yeah, just that explanation and that validation of, yeah, people have missed all these things, and it's not in your head. And
Really sorry. And if you feel angry, that is completely reasonable. And it's, because they feel guilty about being angry at some doctor that told them everything was going to be fine, and then the doctor did something that didn't work out well. And so you give them permission to be where they are.
yes.
And we have 40 and 89 and increased secretions in the vagus to help us do that.
Yeah.
It's so nice to have a tool.
For sure. I'm going to go back to disc herniations and bulges for a minute. They can be very tricky injuries to rehabilitate because of all the guarding and splinting and fear that goes into it. So part of it is, yes, taking off tension and treating hypertonicity in muscles, but at the same time, it's activating muscles to strengthen and to stabilize, and not just in the spine, but in the core, in the abdomen. It's getting people who are quad dominant to start using their hamstrings again. So it's all these little pieces that you have to look at, shine that light on, and get all these toddlers that were having independent temper tantrums to play together in the sandbox. And that's not easy.
It's easier for us than it is for most people.
It is, because it's like you give all the toddlers lollipops and then they're just happy in the sandbox together.
Like, thank you very much. You fixed it. It's like taking a thorn out of the lion's paw.
Yes. You know what? That's so funny that you say that. I had a patient say that yesterday because they had heel pain, but it was actually tib anterior. And once I got at it, they're like, oh, it's like the thorn in the paw. And I'm like, I love that analogy.
Yeah.
Let's get at some questions or comments before we go too far. If there are any, I see that there are some.
I leave.
All right. We have
Oh dear.
L4 through S1 fused, C2 through T1 fused, but not
What?
what? Yeah.
Okay.
Am I reading that right? Yes.
C2 to T1 fused but non-painful. Awaiting surgery to fuse L1, L3 to L1. Wow. Okay, so L4 to S1 are fused. When you walk, your pelvis does this, which makes your low back do this. If they fuse L4, 5, and S1, all of that rotation is going to happen, called shearing, is going to happen at L3. So that's going to create a disc bulge, probably stenosis at 3. So now they're going to fuse L2 and L3, bone and bone. It's another conversation. The disc at L3 is degenerated because it's been doing this ever since they fused 4, 5, and S1. So there's two things. One is treat the disc and the facets at 2, 3. But the most important thing is actually to get the thoracic spine to move. The cervical spine doesn't move. The lumbar spine will pretty soon not move at all. And I know this because the PTs that dealt with my low back and my neck, their number one priority was to get the adhesions out of the nerve roots and get the thoracic spine to rotate. Something's going to move when you walk. And recently discovered an aortic aneurysm, possibly from high blood pressure due to the pain from the degenerative disc disease. Just a wild guess I would check for hypermobility. The aorta has got a very dense basement membrane of connective tissue. I'm not sure how old this person is, Michelle, but in order for all of these levels to have been fused, they had to be injured in such a way that they moved too much, which points me just to find out. It may not be there, but it makes me think of connective tissue, Ehlers-Danlos, hypermobility. So this is fused, that's fused. How is the vagus doing? Treat 124 and 77. And the high blood pressure, the other thing you need to check for is sleep apnea. Number one cause of hypertension besides pain is sleep apnea.
Mhm.
It's just, yeah, wow. Undiagnosed autoimmune. Okay, this is exactly how I follow the breadcrumbs. So this part of the story, all the fusions, then the aortic aneurysm, you at least need to check for hypermobility or historic hypermobility. Is it possible to have an autoimmune condition if the vagus nerve is working? Patients that are hypermobile have vagus nerves that don't work. That's a given, because there's little pieces of tissue. The vagus picks it up, tells the brain, hey, something's wrong. The brain says to the vagus, okay, we don't need you right now, so you go to sleep. All three of these things, the aneurysm, the autoimmune disease, and all of the fusions, make me think about the vagus and hypermobility. Does that make sense to anybody? Yeah, okay, good. Because at this stage, it's too late to fix it. When she was 30, or he,
Yeah.
maybe. But with all these fusions, they're probably in their 60s.
You said
55, yeah. But you can get you can get the vagus working, quiets down the midbrain. It depends on how big the aneurysm is, just 124 and 77, torn and broken in the connective tissue, and the advances of frequency for the aorta. And
Yeah.
do a sleep study. Does that make sense?
Yeah.
Oh,
All right.
look at all the questions. Okay,
We have to
move along.
Yes.
More.
More. So now urinating 2 times in a row in a way. I don't see what it is. I just see what the question is because I didn't really
Understand it.
So they're urinating and then they stand up and they still feel their bladder hasn't emptied.
So they have to go back and empty it.
I think that's how I'm reading it.
That actually makes sense, because the adhesions in the C-section area are adhesions to the bladder.
Yeah.
So now the bladder, instead of it makes sense.
After urinating.
Oh, leaking after urinating. That's, I'd say that the C-section adhesions inhibited pelvic floor strengthening.
Yeah.
So that's going to be the next step, is getting the pelvic floor stronger.
Yes.
Kegels and whatever.
Yes. FSM for Epstein-Barr virus. Symptoms keep reappearing after 8 months. They've tried standard herpes, including post-herpes as well, drained lymph, liver support, also done concussion in vagus. Symptoms which continue are swollen glands, rashes, sore muscles, headaches. FSM helped a little bit, but at present, the only thing that it's helping is the client is working out 4 to 5 days a week, swims in the cold ocean 1 time per week. He says this is what reduces the length and intensity of the episodes and at least reduces the swollen glands when those symptoms arise.
I treat the immune system and I do blood work and find out what the white count differential is. Order a CBC with differentials and find out what the immune system's doing. Sore muscles, headaches. might also treat virus. So herpes is a virus, right? So treat the virus frequencies in the vagus, maybe, or at least for the headaches. Swollen glands, rashes are vagal as well. Immune support, vitamin C IVs, if you can. Why swimming in the cold ocean makes it better. That would put a lot of stress up. Working out, yeah,
Working
go.
out and swimming, anytime you're exercising and you're increasing circulation is going to help.
Saunas,
And,
increase temperature and kill the virus.
maybe cold swimming turns on vagus.
It's a stressor, so I'm not sure how that works. Cold reduces the swollen glands. Interesting. Derek, any good luck with that one? Infectious disease is like my worst subject. It's why we have Jen Sosnowski and David Musnick back so often, because it's my skill set. Any help with suggestions for anger coming from 88-year-old with dementia? The dementia last year and the year before, the anger comes from the limbic system and from inflammation in the brain. So turn on the vagus, because that increases nitric oxide, it increases circulation, it reduces glutamate, reduces inflammation. And what happens in dementia is all of us have a limbic system that gets angry, but we have a cortex that keeps our mouth shut and controls the expression of that irritability or irritation.
Mhm.
I wouldn't, the 970s, because this isn't the emotion of anger, this is inflammation in the brain. Does that make sense?
Again, it's going back to not the surface of the symptom.
Yeah,
Find what the driver is.
the cause.
Yeah.
And dementia is inflammation in the brain. That section, so I'm working on the advanced slides today, and there's that section where I created the protocol for dementia for Alzheimer's,
Right.
based on the frequencies we have and what the science says about the progression of Alzheimer's, from inflammation to necrosis and plaque. And then I was going to send Roger Billica's neurotransmitter slides to a friend of mine who is interested in and has been around in the psychoneuropharmacology, fibromyalgia world for 20 years. And I read through the 2016 version of Roger Billica's neurotransmitter, Molecules of Behavior. I don't know that I watched it the day that he gave it, but the 2016 version has this whole section at the end that made me order 2 or 3 supplements I wasn't taking. And it's brilliant.
And people can access that how?
So yeah, they can either
Purchase it individually at the
or
website.
get the buddy
It's included in the FSM Buddy Plus.
subscription.
Yeah. And the Buddy Plus is for your phone, but if you purchase it from Frequency Specific as a separate item, you get the slides.
And that's, I think, the important part for Roger's presentation.
I go back and reread them at least twice a year. And for some reason, I didn't stop at dopamine this time. I kept going for another 40 slides. But in 16, we hadn't started treating the vagus yet.
Right.
And so it's not part of the neurotransmitter workshop and reducing glutamate increasing serotonin. The vagus increases serotonin, reduces glutamate. And when you reduce glutamate, you increase GABA. And it's so cool.
Yes.
Yeah. So I modified the slides just a little bit. Sorry, Roger, if you're listening.
No, because we didn't know what we didn't know.
Yeah.
And
Then I was still afraid of treating the vagus.
yeah, I think we needed to respect the vagus, and which we all do.
Yes. Once you see it, you can't ever unsee it.
No.
Yeah.
That is a true story. So I had a couple quotes that I wanted to say at the end because I wasn't sure where today was going to take us. I never really know. Sometimes I have a plan, and now I'm learning to be more adaptable. But the one I'm going to choose to close with is healing is a matter of time, but it is sometimes also a matter of opportunity.
Oh, amen. Yeah. Yep. And one of the things I say to patients is people don't find us by mistake.
Yeah.
Yeah.
And like I said, I think it's just a good tie-in to the patients that we're told your MRI is fine. And no, it wasn't then, most certainly is not going to be now. So this is an opportunity to heal with time, but now to gain a clearer picture and to create a better map or path forward.
I have a friend who said that he started using a CPAP last October. He said, I've sleep apnea. I said, when did you get your sleep study? He said 10 years ago. And I wasn't shown the results of the sleep study. The doctor that read the results at the VA just said, you shouldn't sleep on your back. That's all he said. The patient has hypertension that requires 2 or 3 medications, anxiety, depression, fatigue, all of that. And he recently, like last August or September, asked for his records and saw the sleep study that was done 10 years ago. And he was moderate to severe 10 years ago. And it's like the MRI report. I think maybe one of our goals is to teach patients to be better self-advocates.
I've been finding that sometimes they do need that cheerleader, right? Where I'm just like, you have every right to fight for another study, fight for more imaging, change your primary care provider. That is a choice that you get to have, and find someone that's going to listen to you.
Yes. And they're out there. We just have to find them.
Yeah. I'm creating a nice little bank of people that I can, and it feels good. I do too. He said, I don't have to fix it, but I know somebody that can. And that gives me just as much joy, if not more.
Exactly.
Okay.
I like that part. It's 4 o'clock already. Oh, where'd the dog go?
I'm at my feet. You want to say hi to Carol? Yep. Come say hi to Carol.
What's her name?
Zuri, short
For Zurich.
Yes.
Is that the one that's had dinner with her head in my lap? That's the one. And I got your silver lamb.
Yes. Yeah. He's here too.
We have to keep Ellie out of here because
Too distracting. Yes.
there's that.
All right, everybody. We will
See you next week. Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.